Greetings. Welcome to the third annual Carl Rinne Lewy Body Dementia Initiative Symposium with keynote speaker Brad Boeve. I'm Hank Paulson, and I direct the Rinne Lewy Body Dementia Initiative. That initiative was begun because Carl Rinne went through the hell of Lewy body and failure to make a diagnosis for quite some time. He and his wife both were, I think, very grateful for the diagnosis being made here by Dr. Judy Heidebrink. When he died from Lewy body dementia, his wife, Tamara Reel, had the vision to start an initiative that would improve our understanding and awareness of this still not very well understood condition. And out of that, and the generosity of Ms. Reel and her many friends, we've been able to establish an initiative that has led to support groups across the state, things like the symposium today. This is the first year that we don't have Tamara with us. Tamara died from ALS this year. So this lecture today, in my view, is in honor of Tamara for her vision in starting this symposium. We are very fortunate to have today an outstanding leader in Lewy body dementia, Dr. Brad Boeve. He's a Michigan native. He grew up in Holland, and his last visit to this university was when he interviewed for residency. Sadly, he went elsewhere. He did his training at Florida and Mayo, stayed at Mayo, did a sleep fellowship, did a behavioral neurology fellowship. He is now the chair of the behavioral neurology division in the department. He is the little family Lewy body dementia professor at the university at Mayo. He is a world leader, not simply in Lewy body dementia, but also in REM sleep behavior disorder and FTLD. Published over 500 papers in his career, and they're not all papers in which he's buried in the middle. There are many papers on which he is the seminal author who drove things. I'm really impressed with what he's done in biomarkers and is doing in biomarkers, not only in Lewy body dementia, but also in FTD right now. I've also had the chance to see him as a fantastic leader of the National Consortium of Research Centers of Excellence in Lewy body disease, of which both the Mayo and we are members, but he's chair of the division. He does a fantastic job of marshaling experts across the country as we try to understand. Without further ado, let me turn it over to Dr. Boeve.
Thank you very much, Hank. Good morning, everyone. It's a real honor to be here, as Hank mentioned, and as I mentioned to others, as my Michigan roots. I was born down the road in Beaumont Hospital, actually 55 years to the date today, and grew up in Holland, moved south, said I would never, ever move or live in the north again. I've been in Minnesota for 27 years, so don't ever say never. But it's a real honor to be here, and to the Rinne family for having the vision to support something so important. So, well, these are my disclosures. The main things of relevance is we don't have any FDA-approved agents for treating any of the aspects of Lewy body dementia, and I will talk a little bit about some devices that are not FDA-approved for the indications that we'll discuss. And this is what I'd like to cover. First, a brief overview. I know a lot of this information will be a review and well known to many, but we'll try to present some relatively new research findings as well. Go over the overview, clinical features, the diagnostic criteria that were updated last year, the neuropsychological features, a number of neuroimaging features, knowing the strength of neuroimaging in dementia, particularly LBD here. Spend some time on management, clinical course and prognosis, and what's particularly interesting, at least to me, is the prodromal aspects of DLB as we look towards the future and hopefully can impact milder forms or even the prodromal syndrome and delay the onset, and then discuss research priorities and future direction. So first, an overview. When I was in training, and this was just when the McKeith criteria were first published, we didn't know what Lewy body disease when I was a fellow, and then saw 3 patients in 1 week that had hallucinations. Their memory was relatively okay. Two of them had RBD, REM sleep behavior disorder. And this, like a lot of people, as you go through training, some of your first cases are so distinctive. So that first patient with RBD that I saw, we published this case many years ago. His wife described witnessing her husband running in bed like this, and then jerking the arm like this, and then throwing his arms up. He had just run for a touchdown, spiked the football, and was being jubilant. And she was struck as part of the exuberance after the touchdown. So it's hard to forget an episode like this. But back then, we thought Lewy body disease was primarily a brain and primarily a cortical disorder. But over the years, it's been appreciated. This is a systemic disease. It affects the brain, brain stem, spinal cord, and the peripheral nervous system, especially the autonomic nervous system. And this leads to the wide array of symptoms and the complexity of trying to manage as well as diagnose patients with Lewy body. And that Lewy body is an example with the alpha-synuclein. So one way to view the clinical manifestations of Lewy body disease, and this is true whether the phenotype is Parkinson's disease or dementia, the cognitive features, neuropsychiatric features, including hallucinations, delusions, apathy, depression, anxiety, motor features, primarily Parkinsonism, sleep-related issues, not just REM sleep behavior disorder, but a number of other sleep issues that we'll talk about, autonomic dysfunction, and then primary sensory dysfunction. And this has also been helpful to try to conceptualize this as you talk with patients and families and get a sense what are the symptoms that are most bothersome, so you can decide how to attack management. And I'll come back to that in a few minutes. So first, the clinical features. These have been the core features, at least the top three, for well over a decade. Spontaneous Parkinsonism, meaning unrelated to antidopaminergic agents. Visual hallucinations, and this is not meant by a fleeting mouse-like creature off to the side of the vision, but in primary visual gaze, the perception of people, often little people or animals or insects. Sometimes these are quite frightening, and delusions and paranoia develop around them. Fluctuations in cognition and or arousal. This is the most nebulous and hard to operationalize feature. When you hear it spontaneously, it's quite obvious. You know, my loved one can do things, play golf, and then come home, can't even sign a check. So when you hear that, it's obvious. But trying to pull this out, does your loved one have fluctuations or are things even keel? You'll hear fluctuations from really anyone with a cognitive syndrome. So it's hard to be convinced in a lot of patients whether they have fluctuations. And then over the past 10 to 15 years, REM sleep behavior disorder has been found to be not only common in DLB, but the most predictive feature in the setting of dementia to represent underlying Lewy body disease. And for those who aren't familiar with RBD, I'm sure most are, but this is a parasomnia where the patient seems to act out dreams. The dream content typically has a frightening or nightmare quality, usually with the person being chased or attacked. They're the defender rather than the attacker. And yelling, screaming, swearing, punching, kicking, those are the more dramatic examples. And if the person is awakened, then they'll report the content of the dream and it'll match the behaviors that were just exhibited. The problem with this is the nightmares are unpleasant and patients would rather not have them. And also injuries can happen. If you're on warfarin or other agents, this can really be a serious medical issue. So it would be good to suppress. So RBD is common. And in an analysis we did several years ago, these are 78 patients. They were clinically diagnosed with DLB. This is the data from their polysomnogram. Now, granted, this was not research. This was a clinical PSG, so they were having polysomnograms for a reason. But it's pretty striking to see how abnormal their sleep aspects are. So over 80%, and this is true for most studies, that over 80% of DLB patients have RBD. Almost always RBD precedes the onset of cognitive and motor symptoms. In this cohort, obstructive sleep apnea was common. Periodic limb movements with arousals were common. A term that's not used all the time in sleep medicine, but we often use this term, AFNARs, arousals for no apparent reason. And so when you do a PSG, these repeated arousals unrelated to disordered breathing or PLMs, and this is very frequent in Lewy body disease. It's frequent in Parkinson's disease as well. And sleep efficiency is very poor. So about half of them were sleeping less than 70% of the time. So sleep is very disrupted, and hypersomnia is quite common. And it's probably multifactorial, as shown in that data. Many have sleep apnea, AFNARs, reduced sleep efficiency, but some seem to have hypersomnia even when everything else is treated. And it may be inherent to the Lewy body disease disorder. And this is data presented a little while back showing the Epworth sleepiness scores in a group of DLB patients compared to Alzheimer's dementia and FTD. And you can see that most of the DLB patients score 10 or higher on the Epworth sleepiness scale, which is generally considered abnormal. And you can see in this same data set the frequency of patients who have mild dementia. Hypersomnia was a lot higher in DLB. So it's rare to see a DLB patient that isn't hypersomnolent. And frankly, in my experience, I have yet to meet a DLB patient that doesn't have one or more primary sleep disorders that have not been recognized or treated. And so it's very common, very commonly overlooked. And if there's one point to emphasize, treat the sleep disorders. In DLB, diagnose and treat. They can tolerate a polysomnogram. Many of them can tolerate nasal CPAP therapy, and it's really a point worth emphasizing. This is one more set of data in a comparison of DLB versus Alzheimer's disease using the MSLT. And the point here is the lower the scores on the MSLT over these naps. This is the DLB curve, the AD curve is here, and falling asleep on average around 6 minutes. That's quite abnormal, and just more evidence of DLB. But neuropsychological features, most patients with DLB have impairment in attention and executive functions and or visual-spatial functions. Memory can vary. It can be essentially normal, or it can be mildly to moderately impaired, and language tends to be less impaired. These are some examples of performance on visual construction tasks, and these are obviously dramatic examples. Not near everyone has impaired performance like shown here, but with the Necker cube, the clock, and the Ray-Osterreich complex figure, you can see the impairment. And it's quite striking how mild DLB struggle on this compared to mild Alzheimer's dementia patients. That ability to see a two-dimensional line drawing translated into the motor effort of drawing, that circuitry just is impaired in most people, and that anatomy still isn't fully worked out either. If you plot out their neuropsychological performance, there is a distinct difference in most DLB patients compared to Alzheimer's disease. And this is a bit busy, but the main point here is the lower the bar, the more impaired the performance on that measure. These are memory measures in red, language in green, attention and executive in yellow, visual spatial in blue. In a mild Alzheimer's dementia patient's impairment is greatest in learning and memory, and less so in the other domains. Whereas in DLB, performance in memory is more normal, but impairment in the attention, executive, visual spatial is impaired. And a point worth emphasizing, when you meet with DLB patients, they and their family members, they almost always report memory is impaired. There is an element of forgetfulness. But in the testing environment, they rise to the occasion and they perform better than they do functionally. And it may just reflect that when in a testing environment, that ability is better. But that in everyday life, they're just not attending that well. So that neuropsychological profile is pretty distinct. Imaging, I know this is well known among many here. These are coronal T1 weighted images of an example of somebody with DLB on the left and Alzheimer's dementia on the right, mainly demonstrating the hippocampal atrophy that's common in AD dementia and essentially normal volume on MR. So nice plump hippocampi here. And if you actually study volumetrically MR images cross-sectionally and longitudinally, there really isn't much difference compared to normal controls on MR imaging. It really emphasizes that while there is neuronal loss in DLB, the degree is much, much less than in Alzheimer's disease dementia, arguing that the substrate for the cognitive impairment is more neurotransmitter, synaptic, neuronal dysfunction as opposed to overt neuronal death. That's more typical of FTD and AD. On Fdg PET imaging, these are statistical maps compared to a normative base. So black and blue is normal, and the other colors are abnormal. This is a typical, and this is a board question for those who are in training. It's on every board exam, PET scan for Alzheimer's disease. Temporal, parietal, frontal, sparing of the sensory motor strip, and sparing of primary occipital cortex. This is the typical Fdg PET profile in Alzheimer's disease dementia. And contrast that to DLB, where there's more of a posterior predilection of hypometabolism. It is worth noting, though, these are textbook images. There's a lot of DLB patients that don't have this classic PET image. And it's also worth noting that what I'll show with PET and DAT and some other imaging, the standard of care in assessing patients with DLB is a structural image, CT or MRI. Not to suggest everybody should have PET or DAT scan imaging, but in hard to diagnose patients or in a research setting, they're very valuable and help to emphasize the confidence in the underlying diagnosis. And then another finding, this was first described by an Australian group, the so-called posterior cingulate island sign. These are axial images with Fdg PET, and what's meant here is in the posterior cingulate, you see this island of normal metabolism. Compare that to a darker gray in Alzheimer's disease dementia. And further studies to try to understand the basis for this was done by Jonathan Graf Bradford and others. And in the cases that have this abnormal metabolism in the posterior cingulate in terms of Alzheimer's disease, there's a lot of tau deposition in that brain region, likely the substrate or at least part of the substrate, and you tend not to see tau in DLB in that region. And in DAT scan imaging, this is a typical double comma sign that's normal in Alzheimer's disease dementia, and usually you'll see a marked reduction in uptake of the tracer on SPECT. So DAT scan imaging or ioflupane SPECT is commonly used in Japan, also in Europe. It is approved by their medical agencies for differential diagnosis of dementia. This is not FDA approved for differential diagnosis of dementia but in a research setting, it can be quite helpful. So multimodal imaging, this is the composite, and the vast majority of patients have variability but distinct differences when you look at imaging. This is some data that we published last year of a series of patients who had dementia, DAT scan imaging, and came to autopsy to try to get a sense of the validation of the findings. And this top row are all interpreted as normal scans, a couple more normal on the bottom, and then some abnormal scans. And the point here is if you look at this data set, as well as the previously published data sets, primarily from Europe, just looking at the clinical diagnosis based on autopsy, sensitivity is 85%. Specificity, though, is 61%, and specificity improves just purely looking at that. So this is an adjunct based on the clinical pathologic findings. PIB and other amyloid ligands are commonly abnormal in DLB. So it's rare, somewhere around 20% based on autopsy studies of clinically diagnosed DLB patients. When they come to autopsy, it's Lewy body disease alone. About 80% have some degree of Alzheimer's changes. It may not meet criteria for Alzheimer's disease, but often diffuse amyloid and to some extent neuritic and neurofibrillary tangles. So the red represents PIB uptake when looking at a DLB data set. And if you combine PIB plus Fdg PET plus hippocampal volumes on MRI, it's pretty easy to distinguish DLB versus Alzheimer's disease. So again, emphasizing the value of imaging in DLB. This is some more recent work showing the value of the poor man's Fdg PET scan, so arterial spin labeling MRI. You can see the posterior cingulate island sign on ASL MRI as shown here. And in the same person, you can see the island sign on Fdg PET. It's not quite as good comparing Fdg PET, but if ASL is pretty standard nowadays in a lot of MRI scans. And so take a look at the axial images on DLB versus Alzheimer's disease, and you'll probably appreciate this finding. This is now tau PET data, and I know Nico and others here have done a lot of tau PET imaging as well. This is AB1451 uptake in a group of normal DLB versus Alzheimer's disease in the temporal parietal region, and this is in the medial temporal region. And it's obvious Alzheimer's disease, much greater uptake, and this shows a differential uptake in DLB. So some degree of inferior temporal occipital uptake, but not medial temporal uptake in DLB compared to Alzheimer's disease, which is really quite interesting. Why that differential topography of tau deposition between the two disorders? Maybe this has some explanation for some of the clinical manifestations, but that remains to be seen. So these are two examples. The top one is PIB positive, the bottom one's PIB negative, showing the uptake in the inferior temporal occipital in both of these cases, more robust in this one than here. And we're still early stages of tau PET imaging in DLB, but and what would be very nice is to do this in MCI of the Lewy body type and characterize this more. Moving on to the diagnostic criteria, again, these were just published last year. So the last international DLB conference was held in Fort Lauderdale in 2015, and it was a fun and very productive meeting. And with the updated criteria, I know nobody can read this, but the main points are the core clinical features, again, Parkinsonism, hallucination, fluctuations, RBD. 2 or more of these define probable DLB, or if one is present and one of the indicative biomarkers are present, that meets criteria for clinically probable DLB. Since these were just published, we haven't been able to follow enough people prospectively to autopsy to validate this, but that's obviously in progress. So some of these indicative biomarkers, DAT, we've already reviewed. But we haven't talked about MIBG, and this may be one of the most sensitive imaging markers for Lewy body disease in general. This is Parkinson's as well as DLB. And in Lewy body disease spectrum disorders, the absence of uptake on MIBG compared to Alzheimer's disease and normal controls. This is routinely done in Japan and a few other places. It can be done in most places in the US, but the cost is the prohibitive factor. And plus, if the person has diabetes or other potential confounds, it limits the ability to do MIB. But the data, though, is very compelling that this is a sensitive marker. And then this is an example, a 30-second fragment of PSG clips of normal EMG tone during REM sleep. These top two leads represent REM sleep. And this is chin, arm, and leg leads showing the normal active suppression of EMG activity. And this is an example of somebody with a clinical RBD. The terminology for just the polysomnogram is REM sleep without atonia. So this person's in REM sleep, and you can see the obvious EMG tone. So when doing a polysomnogram in somebody with RBD, whether they have a DOB or not, it's relatively rare to see a lot of textbook video examples of the punching and kicking. The more standard is this PSG evidence. So it can be a relatively quiet night in the lab, but the electrophysiology is usually pretty striking. And so it's not hard to make a diagnosis of RBD. The neural path features, the main point here is even the presence of limbic Lewy bodies is sufficient to result in a dementia syndrome. We commonly think that dementia is from cortical Lewy body disease, but there's many, many limbic predominant cases without any neocortical Lewy bodies that have a full dementia syndrome. So Lewy bodies are necessary, but not required in the neocortical region, at least, for a dementia syndrome, which a lot of people were surprised by this finding, but many groups have found this. Management. This has been a challenge, and as Hank was mentioning, there's now the Research Centers of Excellence program across the United States. There's 24 centers, and the mission of the RCOE program, as it's called, is to improve and optimize clinical care, and second is to develop and optimize a clinical trial infrastructure. Hopefully, using this, we can better approach how do you manage these patients. As a clinician, they're quite fun patients to see. They're challenging, but they often get better. Sometimes they get a lot better, but it's not a single pill. It takes a lot of work. And the best approach that many clinicians have found, you have to tackle this in a comprehensive manner. So talking with the patient and family, what are the cognitive issues, neuropsychiatric, motor, sleep, and autonomic, and engage with them. What is the highest priority symptom complex that we should work on? Direct therapy towards that. Hopefully that will improve, move down on the priority list, and then the others will raise up, and then you start all over again. And so this may take weeks, months, over a year to optimize treatment across all of these domains. And as everyone knows, doing this in clinical practice, especially in an academic center, our practices are not set up for seeing people back within weeks or even frequently for months. It's a challenge, but we have the expertise to do this. And so trying to balance the clinical and frankly payment aspects of clinical practice, yet the clinical benefits of this approach, we're not sure how this will play out, but it's worth the effort. This is the armamentarium that we have. Again, none of these are FDA approved for DLB specifically, and I'll go over a few of the papers supporting this, but cholinesterase inhibitors, most commonly either donepezil or ribostigmine, are used. There is some soft data that memantine can be beneficial, although most people in clinical practice haven't been all that impressed with that agent. The hallucinations can be a bear to manage, and although the data don't support the use of atypical neuroleptics, many clinicians feel that they're justified, and maybe we can talk about this more. Depression is very common, and selecting good antidepressants for treatment's important. If Parkinsonism is present, then levodopa is standard. The dopamine agonists tend to result in a lot of hallucinations or worsening hallucinations. So managing Parkinsonism in DLB is not easy. And then if warranted, using agents for RBD or some of the other sleep issues. This is quite controversial. Clonazepam works very well for RBD, but in anyone with cognitive impairment, there's an obvious reluctance to use that agent. The standard of care nowadays at most places is to use over-the-counter melatonin, 3 or 6 milligrams per night. It works about half the time, and it tends to be much better tolerated. But there are plenty of people where it just doesn't work, and so other agents are needed. And I should say that in RBD, there never has been a double-blind, complete placebo-controlled trial for management of RBD. It's just basically clinical practice. This is what we do, but we don't have evidence to really support it. And then I'll show some data in just a minute of using psychostimulants. This is also a controversial area, but if these patients are sleepy, and if their sleepiness could be improved, such that alertness is better, cognition improves, perhaps even the neuropsychiatric features go down, then they may have a role. And this is what we found. So these are just some of the papers supporting the use of cholinesterase inhibitors in DLB. These are largely outside the US. This is the 2 for memantine. And then the experience with levodopa, and most recently, and I'd be really curious if anyone's used zonisamide for Parkinsonism, especially in DLB. I haven't used it much yet, but there's good data in this paper that was published recently for the use of Parkinsonism. This is, excuse me, this is data from a small study we did a couple years ago involving 20 patients with DLB. These were all hypersomnolent. And it was an open label study in 20 patients with armodafinil. This is not meant to tout a particular drug. It's more a proof of concept. And so with these 20 patients, the goal was to see, would a wake-promoting agent improve sleepiness? And also, would it improve cognition and or the neuropsychiatric features, especially apathy and visual hallucinations? And in the majority of patients, it did improve sleepiness. So this is the Epworth Sleepiness Scale, and this is the Maintenance of Wakefulness test. And these data show at baseline compared to 4 weeks later, on armodafinil, 250 milligrams per day. Each of these lines that go down represents improvement on the Epworth, and each of the lines that go up on the MWT represents improvement. But for those who are familiar with the Epworth and the MWT, you'll see that despite treatment, a significant proportion of these patients still score in an abnormal range. So even though they improved, they didn't improve a whole lot, at least in the normal range. They did not improve on cognitive measures. Hallucinations and apathy did improve. So you would think that there's a concern that a psychostimulant may worsen hallucinations, but that's not what was found. And this is also, if you use psychostimulants or wake-promoting agents to patients with narcolepsy, alertness improves, cognition can improve if there is some degree of cognitive impairment, and hypnagogic, hypnopompic hallucinations, well as cataplexy, tend to get better or improve. So there are some similarities between some of the narcoleptic features and DLB. And so the main point here is wake-promoting agents may have a role, but it's since this data was published, my sense is some clinicians view this as, okay, we'll use Nuvigil or armodafinil and not pursue obstructive sleep apnea, optimizing non-drug therapies for sleep maintenance. So it's not to suggest jumping with the drug, but to, again, attend to the comprehensive sleep issues. Many of these patients have obstructive sleep apnea that should be assessed and treated. I often show this grid, and it's complicated, but that's the state of affairs. So in seeing a patient, trying to get a sense from them and the family members, these are the domains that we can try to attack. These are the classes of agents that we have that we can select. Those boxes that are in dark green often are positive. Those that are yellow are more cautious, and those that are red are the downsides. So, for example, if a person has severe visual hallucinations and you feel compelled to treat it, the atypical neuroleptics may improve hallucinations and or delusions, but cognition could worsen, Parkinsonism could worsen. They often become more sleepy, and orthostatic hypotension worsens. So this is always this balance between trying to manage symptoms you want to attack and not resulting in significant side effects. And this, again, as a clinician, I find this quite challenging, but also rewarding as you go through this process and you just do your best to find that cocktail that works best. There are some other downsides of each of these classes of agents. Some of them are clinical, things like clozapine. You have to worry about blood counts. And then some of these, the QT prolongation can happen. So again, there are some downsides. It is critical with every patient to engage the Lewy Body Dementia Association, if in North America, Lewy Body Society, if in the UK. There's a similar society in Australia now. So it's a fabulous organization, a lot of good web material, and the support groups such as in and around Ann Arbor. It's an alliance with the Lewy Body Dementia Association, and this is only going to blossom over time. So as you see patients, if not already doing it, have them go to the website, and they welcome phone calls too. What's their clinical course? This is data from a cohort of DLB patients that we followed many years ago. It was about 80 patients, trying to map out based on history alone, what was the temporal sequence of the evolution of symptoms. And this may be a little bit hard to see, but it's a Kaplan-Meier type curve showing that most patients had the onset of RBD, then cognitive changes, then Parkinsonism, then visual hallucinations. So when you look at a group set, this is the usual evolution. So if you map this out, RBD first, then years later, cognitive decline, then Parkinsonism, then hallucinations. But there's a significant minority who don't follow this rule. So this spectrum, it can occur in any sequence. But this is the prototype. This is data from Doug Arslan and his group. His group in Europe has published widely, very prolific in Lewy body disease. This is showing, based on the MMSE, an Alzheimer group decline over time compared to the DLB group, and you can see the slope is steeper in DLB, and that's the recurring theme. DLB progresses faster and has more significant impact compared to Alzheimer's disease. This is another data set showing onset to hospitalization is about 80% will be hospitalized. This is a European study also within 2 years compared to Alzheimer's disease. Yeah. Often hallucinations. It's often the psychosis that results in hallucination. Sometimes falls, but it's usually the psychosis. And then survival, DLB is in red, AD is in blue, and you can see the survival curve is steeper in DLB. This is a study recently published by Melissa Armstrong and others. What happens to people with DLB? What's the cause of death and other factors? So this is a large group of DLB patients. The most common cause of death, for lack of a better term, is failure to thrive. Second most common is aspiration pneumonia. Third, a number of medical conditions. Sometimes, at least it's been attributed to antipsychotic effects, and suicide, about 1%. This is probably higher, and I'm sure many are aware of Robin Williams' experience, and we've had a few individuals where this has happened also. It's really the insight is preserved in DLB, and highly successful people who struggle and are not getting the help that they're seeking, one can see at least why this might happen. In this data set, median survival was 4 years. A sad thing, and I think it emphasizes for all of us who are clinicians, is we need to have end-of-life discussions with DLB patients. And in this cohort, only 40% had a discussion. And hospice was involved in about 70%, but this is always difficult in dementia when to engage a person with dementia in a hospice care. It's just hard to predict. But at least to involve the palliative care clinicians, and they can help with that transition. And then these are 2 studies that our group did looking, this is looking at NAC data, National Alzheimer's Coordinating Center data, based on path-proven cases. And this is kind of what you would predict. Those that had diffuse Lewy body disease had a more rapid rate of decline compared to those with limbic predominant Lewy body disease. And then this is also what you would expect. Those that had primary Lewy body disease without Alzheimer's changes had a slower rate of change. If you have coexisting Alzheimer's disease, the rate of decline is much faster. So pathologically, those 2 aspects make sense. And then finally, impact. This is another European study comparing DLB, which is in the crosshatched, the costs associated with care, compared to Alzheimer's disease, which is the white open bar. And you can see at baseline and subsequent years, DLB is much higher than Alzheimer's disease. So, and in some countries, for example, Denmark, they actually have very well characterized data. DLB is very expensive compared to Alzheimer's disease, where this can be quantified. Let's spend a few minutes on prodromal DLB. This, I think, is really exciting work. It's complicated, but can we better characterize Lewy body disease patients prior to the onset of a full dementia syndrome? And these are the thoughts on what is prodromal MCI, so prodromal DLB. So MCI, and we'll talk about this in a minute, neuropsychiatric syndromes, either refractory depression, an apathetic state, so often presenting to psychiatrists before neurologists, or isolated hallucinations and delusions. Recurrent delirium, and most people in the U.S., they don't quite buy this recurrent delirium. It's in Europe, this is pretty well accepted that recurrent hospitalizations for delirium may be a part of the Lewy body syndrome. They develop dementia later. And then isolated REM sleep behavior disorder, and we'll talk about this more in a minute too. I'm purposely using isolated as opposed to idiopathic RBD because most people now don't view RBD being idiopathic in most instances. Most people with RBD have underlying Lewy body disease, but we'll come back to that. So MCI, there's been a lot of work over recent years on the MCI of Lewy body disease, and this is data from our center from a few years ago. This is 10 patients that were followed over time prospectively, diagnosed with MCI, followed prospectively, had an autopsy, and Lewy body disease was found at post. And for this example, RBD began in his 20s. Much later, cognitive and Parkinsonism changes occurred at 74. MCI diagnosis at 75. Donepezil was begun. 2 years later, diagnosed with DLB, and then much later died. This was his neuropsychological profile, showing a non-amnestic type of profile. And if you look at 8 of these cases, this is their MCI profile. The point here is any MCI syndrome can represent Lewy body disease. Most of them present in a non-amnestic manner with executive and or visual spatial dysfunction. And many other groups are finding the same thing. This is an analysis that we did a little while back. Again, prospectively, 327 MCI cases followed over time. And this is what you would predict also. Non-amnestic MCI tended to evolve to DLB. Amnestic MCI tended to evolve to Alzheimer's dementia. So it looks like the MCI of DLB is not that difficult to characterize. And if there's REM sleep behavior disorder plus MCI, I'm not aware of any autopsy cases that's not Lewy body disease. So it looks quite predictive. Now, what about preceding MCI? And this is where we get to REM sleep behavior disorder. If you study those with, again, so-called idiopathic RBD, and you do any test that's abnormal in Parkinson's disease or Lewy body dementia, again, do this in those with pure RBD, you will find impairment on a significant proportion. Again, arguing that a significant majority of RBD patients have underlying Lewy body. And so this is all the measures that have been done in RBD. All of these have been shown to be abnormal. Ron Postema and his group in Montreal, the Barcelona group, have done some very nice work and very consistently showing the same thing. This is data from North America and Europe of individuals with RBD, PSG proven, who came to autopsy. And as you can see here, 98% of them had a synucleanopathy. The breakdown, 3/4 were Lewy body disease, almost the other quarter MSA, and some individual cases of Alzheimer's disease and PSP. So it's not 100%, but it's very high. And the thought now, and this is a bit controversial, but can we apply the Braak staging for Parkinson's disease to DLB? And in a lot of respects, we can, but it's not real straightforward. So for those who aren't familiar with Heiko Braak's work, he proposed this staging system for Parkinson's disease, not Lewy body disease in general, but Parkinson's disease. 6 stages, stages 1, 2, 3 were in the pre-symptomatic stage. And basically what was proposed is that this is an ascending degree of topography of alpha-synuclein deposition, beginning in the medulla, then pons, then midbrain, and then limbic and neocortical structures. And if you apply this then to what we're talking about, this is a schematic showing the brainstem and the nuclei that we believe in humans. This is not proven, but what we believe in humans is a substrate for RBD. The sublateral dorsal nucleus, which is just caudal to the locus ceruleus, the magnocellular reticular formation, or both of them. Normally, they're unimpaired, and therefore during REM sleep, there's active inhibition of locomotor neurons and no EMG activity during REM sleep. In those with RBD, there's degeneration in either or both of these nuclei. We think the sublateral dorsal nucleus is the key in humans. That leads to the loss of inhibition and therefore activation with other locomotor generator input on the anterior horn cells, and this shows up on PSG as elevated EMG tone. So this would support the Braak staging. And if you look at this in the concept of DLB, over 80% of DLB patients have RBD years or decades before their cognitive symptoms, but they have varying degrees of Parkinsonism. Some never have it. Most have it to some degree. And so the thought is it still supports an ascending rate of progression, but the nigrostriatal system just is not hit near as hard as it is in Parkinson's. And why that is, nobody understands very well. But typical PD and then typical DLB, it may be the relative topography and severity of the structures. There may be other factors, so this is still pretty speculative, but that's the going thought. Another line of thinking is Parkinson's disease is bottom up and DLB is top down, but that doesn't make sense. Again, RBD is very prevalent well before DLB starts. So it argues for more of a patchy type of change. The European groups have done a lot of work using neuroimaging, focused on the DAT scan imaging. And basically what they found in those with idiopathic RVD, abnormal DAT scan, their rate of a change to Parkinson's disease or DLB is very high over the next 5 years. If their DAT scan's normal, the rate of that phenoconversion is very low. So we're still limited by the data, but based on those elements of data, DAT scan may be the best predictor, but it's still relatively soft. This is just an example. We've been doing DAT imaging many RBD patients, and this is an example of a normal scan and a minimally abnormal one in another individual with RVD. And we're doing serial scanning, and this is a example where not much change, and it's a little bit more obvious change in this individual over 2 years. The problem with DAT is it's a SPECT scan, and good quantitative measures, even though there are software systems that quantify it, the confidence in that is still not super high. So even though the visual data look good, we'd like to scientifically be more quantitative. And so would PET imaging, and Roger and others, we were talking about that earlier, and PET imaging sounds more appealing. And of any place worldwide to characterize it, it's right here. Finally, some words on where the research field is going. This is based on the National Alzheimer's Plan Act, Alzheimer's disease-related dementias. This is now for those who aren't familiar with the NAPA plan, this was set up under the Obama administration. It's been maintained under the Trump administration, and it's pretty strong bipartisan support to have a plan to attack dementia at a federal level. This involves Alzheimer's disease, DLB, frontotemporal dementia, and vascular dementia. And this is the latest addition for Lewy body disease. I know this is hard to read, but it basically covers clinical, pathologic, genetic, biofluid, and a lot of basic science aspects. It's been well thought out, and this will be redone in March at the next ADRD summit. These are some other things that are going on. The Alzheimer's Disease Center program. There's now what's called the Lewy body dementia module. It's a pain to complete. It takes a long time, but it's a lot of good data. And so as we characterize a lot more DLB patients, and this is pretty comprehensive, the clinical data that's done as part of this module, follow them to autopsy, that will really expand our ability to characterize LBD clinically. There's also the Parkinson's disease biomarker program. Kirk has one of the DLB UO1s as part of this. There's 5 in the country, and this has been hard to recruit for. So as you see DLB patients to enroll in the ADRC and the DLB UO1, it'd be really nice to have dual participation. There's the Research Centers of Excellence program that we touched on before. Again, this will likely expand. I'll talk about the NAPS consortium in just a second. And the U.S. is doing a lot, but the Europeans are doing really well in DLB research as well. Japan's probably out ahead of all other countries, and Australia is really emerging quickly too. So doing all the things that we've been discussing, and in talking with Roger and others and Nico, this is still a challenge, and we don't know where, when, or how good this is going to be. But to see what's happened in the Alzheimer field with amyloid and tau imaging, our understanding of biomarker changes is just revolutionary. And if we had an alpha-synuclein PET, presumably we would learn a lot more about PD and DLB, but this has just been hard to develop a ligand, and hopefully one will be developed, and it'll provide insights similar to amyloid now. These are the sites that are in the Alzheimer's Disease Center program around the country. It's about 30 centers. Obviously, one's here, and others spread around the country. And The Lewy body disease module, if anyone hasn't seen this, I'm happy to provide these slides. You can go to see the wealth of data being done as part of this. This is the Research Centers of Excellence program. Again, one of the centers here. The clinical trials that are active in DLB, unfortunately, it's very few. E2027, my understanding, will begin here soon for DLB. At least that's what Rinne suggested earlier, which is great. And the other accidents studies, 2 of them have ended, but one is continuing the open label study with neotanserin. And then pimavanserin or Nucleazid, that is being studied in DLB now too. So, in Alzheimer's disease, there's hundreds of clinical trials in the U.S. And there's very few, unfortunately, but we expect this to change. So as part, again, of the Research Centers of Excellence program, what was apparent 3 years ago with one company having an interest in DLB, there's been over 15 companies that have approached the RCOE with an interest to doing clinical trials. So we suspect we're going to be quite busy over the years to come. And I think the challenge is going to be prioritization, knowing which ones to be involved with and which ones are more, not as exciting. But it's great to see the pharma interest. I'm going to skip this. And then this is the NAPS consortium, so North American Prodromal Nucleanopathy Consortium. This was, in talking with Roger, he was proposing this 20 years ago, and smart minds just weren't ready for this. But obviously a very thoughtful person, very proactive. But this is, it has just begun. These are for idiopathic RBD patients. It's an R34, a clinical trial planning grant, so only 2 years. The funding is quite low, but it's with 7 centers right now, enrolling people with RBD and following them over 2 years with a comprehensive battery, blood, CSF. There was no money for imaging, but the thought here is we've had support by the program officers to go in with a supplement in January, February to expand this. And it'd be great if Michigan, many other centers, and we need imaging, but that obviously is a lot more expensive. But this will be like a lot of the other programs, Diane, lefties that started small, will expand. And obviously, as we characterize the natural history of RBD over time, then we expect some of them will go from normal to RBD plus, so mild cognitive impairment or mild Parkinsonism or both, and then evolve to an overt synucleinopathy. But we need this data for clinical trial design, so that we'll be in a situation to test whether an intervention can delay the onset of MCI or dementia. And most people in the field realistically feel that this is not only within our lifetime, but within the next 5-10 years. But we need the natural history data, and we need some good fortune from the pharma. But hopefully that will happen. One final note, the next International Lewy Body Dementia Conference, this is going to be organized by Cleveland Clinic. Jim Leverance, who I understand was here last year, Marwan Sabah just moved, working with Jeff Cummings in Las Vegas. So it'll be in a very cool spot in the middle of summer. But we'll be in AC. For those who are interested, these are really good meetings, and should be a fun meeting. So I'll stop there. Thank a lot of colleagues who've been in this line of work for 20 plus years, and many other colleagues, including many. So thank you very much for your attention.
Thank you and happy birthday. We have time for a few questions. Dr. Bonin.
Yeah, so for the DET scans that you showed, Brad, it looked at the ones that were read normal. Some of them had diffuse reductions. And the one that were read abnormal with the postmortem validation also had diffuse reduction. If you look at normal aging, we lose about 8% of dopamine transporters every decade of a life since the early 20s. So if you get 75, you've lost like 40% diffusely in your basal ganglia. So what's the cutoff that you use in your practice to say this is prodromal DLB and abnormal DET scan versus normal aging?
Very good question. The normative base for DAT scan imaging is pretty scant. And so at least for our funding, we have 6 normals so far, and most of them are women, so it's not a good fit. If you look at the GE DAT scan data for their DAT quant data, it's a small number. And in talking with other people who use DAT quant, they're not happy with the normative base either. It's really strapping the science. So either we need a lot more normals followed sequentially, or we need to move to a PET ligand. Fantastic question, and that's aim 3. So what's being done, all the PSGs, so they have to be PSG proven, and the EDF files are going to be sent to one lab. We don't have funding for this part yet. We didn't tell NIH that, but actually we'll get from a private donor. But that's exactly the plan. So the degree of REM sleep without atonia, some of the autonomic data you can gather from that data, we think that'll be as or more predictive than some of the clinical data.
Brad, great talk. Could you say, I just want to engage you a little bit more on this issue of PD versus a DLB. And I know there's probably not one answer, but just to kind of give you a little provocative. So if we think about people with genetic diagnosis, SCAs, they can have widely different clinical phenotypes, but we call them the sort of same thing, or people have left ventricular or right ventricular infarct have very different clinical phenotypes. So can you just say a little more about how much you think these are distinct processes versus the same process, and what's the data underlying that?
Yeah, I think it's a very, very good question, and it's still controversial, and we're going by largely hunches rather than good data. I guess my bias coming from the Alzheimer field, if you look at sporadic AD, presenilin 1, presenilin 2, APP, it's amyloid and tau, but the phenotypes are very different, and the mechanisms are probably different also. And so is Lewy body disease this hodgepodge of genetic and sporadic with a lot of different aspects to pathogenesis? They converge with the Lewy body disease in alpha-synuclein dysfunction, but it's just not one answer. And maybe that's partly why the topography skips more in DLB as opposed to PD. So again, it's speculation, but and part of this comes to this 1-year rule. Yeah, a lot of people hate it, but and it's still it's more just to lump different groups to try to get at why the phenotypes are different biologically, but that's still quite clear.
I mean, I just to say I think it makes obvious all the sense in the world given the complexity you've outlined to have certain sets of clinicians from a practical standpoint, look at the motor or the cognitive, because there's a lot of specific issues. But I just wonder if we're missing sort of way to unify because the biology seems so.
Well, I think we solved that. Yeah, I think a lot of work you've done there. Important point.
We were talking earlier that it'd be nice if the ADCs and UDOL efforts could more align. I'm not aware of any center around the country where that's worked really well, but it's an obvious direction to go to.
Well, given the time, we should thank Dr. Boeve one more time.